All right, online students, we're going to finish up my part of this physical assessment checkoff. If you will remember, we went over number 1. That is the biographical data through the functional assessment, ending with the very final thing, perception of health. That is worth 45 points in the first part of your write-up. The second part of your write-up starts with the comprehensive physical assessment, which is what we're fixing to start, starting with the general survey, measurements, and vital signs. Well, how do I know what to put there for 5 points? Good question. If you will download your actual physical assessment checkoff tool, you can see mine is written all over. If you will download that, then as I go along, you can write on it so that you know what to say for that part, because a lot of this is verbalization. If you're just sitting there staring at their eyes, I have no idea what you're looking at. You're going to have to tell me that you're looking at their eyelashes, their eyebrows, they're even, they're evenly distributed, there's no crusting, there's no visible lesions. Otherwise, I have no idea. So you're going to have to talk through a lot of this as well as do it, okay? And don't forget to do it. Don't just talk through it. Certain parts that you get to, you'll be able to say, and I would do that bilaterally. Then you won't have to do both sides, okay? You will have 1 hour to complete the head-to-toe assessment on your partner. At the end of 1 hour, you will be called time. So anything you have not completed after that time would not count. So when you're doing your assessment and you're recording it, make sure that you are watching the clock, because I will look at the time that you send me in. And if it's more than an hour, you will get docked. So make sure that you stay within that hour limit when you're recording, okay? All right, so download the physical assessment checkoff, get my PowerPoint ready, and get your book open to Chapter 9. All righty, let's get started. So from the current slide, all right. Again, this starts on page 127 in your book. And this is where you start your write-up again for your physical assessment, head to toe. When you're getting ready to weigh someone, you want to make sure, again, that you try to weigh them or tell them to weigh about the same time every day. But when they're going ready to weigh, you want to make sure that they take their shoes off and that they're weighing on a flat platform and that you have calibrated the scales. Now, when you're getting ready to do height, you want to, again, make sure the shoes are off. They're looking straight. They're forward looking. And after 2 years old, they can stand on an upright scale. That's the pole scale with the platform scale. Otherwise, under 2, then we do it on the infant baby scales. All right. You do not have to do the vital signs as far as part when you start your physical assessment checkoff. In other words, you won't say the blood pressure was, the temperature was. You will simply come in and state, I've already completed my vital signs. And that's all you got to say. And it's in your write-up what they actually were. At this time, a lot of people will also go ahead and do the Snellen Eye Chart ahead of time. That's where you check the vision, and we'll be going over that, and they'll just state what it was. For example, I come into the room, and I've already introduced myself and getting ready. Okay, before I start, I want to let you know I've already done the vital signs. I have checked her vision with the Snellen Eye Chart. It was 20/20 in both eyes without corrective lens. And then you can actually, if you wanted to, go in and say that assesses cranial number 2, optic, so it's intact. Now I've done a cranial nerve. I've told what it was. I've done the Snellen Eye Chart, and I verbalized the vital signs were done. Now this will all be in my write-up, but you only have to verbalize it. The big thing about weight is knowing what your normal BMI level is, and that's anywhere between 19 and 25 for a healthy adult. So anything over 25 starts getting into the obese category. So you want to make sure that you are overweight after 25, and then the obese category as it gets into the 30s. So you want to make sure that you're monitoring that. Vital signs, it has a lot in here about temperature, pulse, respirations, and blood pressures. I know you know a lot about those already. Please read over that section, though. Very good section. Especially, you need to remember about cuff size and using the correct cuff. If you've got someone who's extra large and obese, you need to use a thigh cuff. If you use cuffs that are way too narrow, then that's going to yield a false positive high blood pressure. If someone's very anxious, then you need to give them about 5 minutes to calm down before you check their blood pressure because it's going to be high. So if you get a high blood pressure, they're anxious, wait about 5 minutes, tell them to take some slow, deep breaths, go to their happy place, and then recheck it. One of the things you may see them doing is checking Dopplers and thigh pressure cuffs. If you have to do a thigh pressure cuff, just know that it is higher than an arm pressure cuff, and it's best if it's done in the prone position. There's a good picture in your book on page 143 that walks you on through how to do a correct thigh blood pressure. You can see here they've wrapped a large cuff about 18 to 20 centimeters around the lower third of the thigh, centered over the popliteal artery on the back of the knee. Then they auscultate the reading. Again, this is going to be, the systolic value is going to be 10 to 40 milligrams higher of mercury than it would be in the arm, and the diastolic the same. But if you can't get it for some reason in both arms, that is a method that you can use. The Doppler technique is also a method that you can use, and I believe that's on over here on about page 152 and 153. The Doppler technique is where you take a Doppler and you use that ultrasonic flow meter to pick up on blood pressure readings. It tells you there on page 153 you would want to apply the gel, then turn your Doppler on, attach the probe to the skin, holding it perpendicular to the artery. And then a whooshing sound is what it indicates you've located an artery. Once you've located, then you inflate the cuff till the sound disappears. Then proceed another 20 to 30 beyond that point. Slowly deflate the cuff, noting the point at where you first hear the whooshing sound. Now, I will tell you, when you are doing a Doppler pressure, you are going to hear it all the way down, just about. So you can't rely on the diastolic pressure. So you only can rely on the systolic pressure. However, if you get a systolic pressure of 120, chances are the patient's doing fine. If you get a systolic pressure of 60, chances are the patient's not doing fine. So even just being able to get a systolic blood pressure through a Doppler will tell you a lot about the patient's status. As far as head-to-toe assessment and starting that, the first thing we're going to start with is what we call the general survey, and that's on the bottom of page 127. So if you look here, you're going to find that in my lecture, I pulled this physical assessment checkoff, and I went over every single thing on this checkoff. If you look under general survey on your checkoff sheet, there's A, B, C, D, E, F, G, H, I. If you look at my head-to-toe assessment on my PowerPoint here, starting with the general survey, there is A, B, C, D, E, F, G, H, I. And I give you a sample of what you can put by each one of those. So the first thing you're going to do, of course, is go in, introduce yourself to the patient, wash your hands, and provide privacy, right? So I'm going in, hello, my name is Marietta Candler. I'm going to be performing your physical assessment today. I'm going to start by asking you some questions, but before we do that and get started, let me wash my hands. As I'm washing my hands, I want to let you know I've already completed the vital signs, and I've already completed the Snellen Eye Chart. Her vision was 20/20 in both eyes without corrective lens. That assessed optic nerve, cranial nerve number 2, which was intact. And now I'm ready to start my head-to-toe assessment, okay? So the first thing I notice I'm going to assess for is the level of consciousness. I've already assessed her level of consciousness. The patient's alert, she's oriented, and she responds to questions appropriately. I can actually assess that at that time. If you want to go into more detail, you can say, can you tell me your name? Can you tell me the date of birth? Can you tell me who's president? Can you tell me where you're at? I mean, you can assess the orientation level if you want, or you can just say, patient is alert, oriented times 4, responding to questions appropriately. Okay. Then D says body size and proportion. If their weight appears normal for their height and body build, that's all you have to say. If they're disproportionate, you need to say that. But if they're normally proportioned, just because they're larger doesn't mean they're not proportioned well. You know, I'm big all over. So weight appears normal for height and body build. Proportions are normal without obvious physical deformities. Okay, so that would get me through that one. Or you could say normal weight for height and build. Proportions are normal. Posture and positioning. That would say, you would say that they're erect for their age. They're sitting comfortably. Their arms are relaxed and their heads turned to the examiner. Gait, balance, stance, and involuntary movements. As they were coming in, I noticed they had a normal gait, balance, and stance with no involuntary movements. As I'm looking at their facial expression, it's appropriate and they're smiling. Observing their mood and affect, they appear comfortable, cooperative, and they're interacting pleasantly. Looking at the dress, it's appropriate for the climate and need, and they appear neat and clean in appearance. And that would be the general survey. So that would be what you would do in your write-up, on your write-up over here, your comprehensive health history and physical exam write-up, number 2. Number 1 states, under number 2, the first thing you're going to see is general survey, measurements, and vital signs. That's where you're going to put this for 5 points. Now, don't go by the sample only, because if you go by the sample write-up of a general survey back there where we've got our sample on page 784, isn't it? Let's see here. Yeah. If you look on page, let's see, the head-to-toe assessment starts on page 787. And if you look on page 787, it gives you how to write up the measurements and then the general survey. For the example on 787, it says Ellen Case, 23-year-old Caucasian male, not currently under the influence, who articulates clearly, ambulates without difficulty, and is in no distress. Can you write yours like that word for word? You can, but are you going to get full credit? No. And why is that? Because that's not what you did. You assess level of consciousness, body size and proportion, posture and positioning, gait, balance, stance, involuntary movements, facial expression, mood and affect, and dress and hygiene. So that is what your general survey should be written up. So even though this is a wonderful example, it is, and you can follow it. Yours is going to say more like Ellen K., a 23-year-old Caucasian male who's alert and oriented times 4 and responding appropriately to question, whose height and build is proportionate. She's sitting erect comfortably with her arms relaxed. She had a normal gait, balance, and stance. She was smiling and comfort and cooperative, and she is dressed appropriately, neat and clean in appearance. That's what an example what you would chart in your general survey for your 5 points. That is also what you are going to have to verbalize. Again, we can't read your mind. If you don't say those things, we have no idea if that's what you assessed for in the general survey. So how do you take this assessment? One bite at a time. So go over and over the general survey till you know A through I, till you can just spit that out. Introduce myself. I wash my hands. I said I've done the vital signs. You need to write that in here. Don't forget to say I've done vital signs in the Snellen Eye Chart. Then, I've assessed the orientation, body size and proportion, posture and positioning, gait, balance, stance, and involuntary movements, facial expression, mood and affect, dress and hygiene. Alrighty then, that gets us then to our next one, which will be our head and face. Okay, so take a big sigh. Right, okay. So our face and neck, before we get to that one, we are going to go over the skin, hair, and nails. Now, the skin, hair, and nails is in chapter 12, so if you'll scootle over to chapter 12, page 199. Skin, hair, and nails. While we're on the skin, hair, and nails, I want to just go over this chapter and tell you from here on out how all the chapters are set up. The first part of the chapters from here on out have a brief overview of A&P, or structure and function. So if you need to review those at the beginning of each page, you can. Each page has subjective data where you can even, where you were asking about those questions. Do you have any excessive bruising? Do you have any rashes or lesions? If they were to say yes, then you can come back to here and it gives you even more questions that you could ask about that. To the side, it gives you the rationale you're asking for that, because that would give you abnormal findings. So you would have a subjective section, and then the next section in each chapter is the objective section. And that data is where you are starting your head-to-toe assessment. In this chapter, it happens to be page 206. So when you look on page 206, that starts the objective data collection. That's the head-to-toe assessment, and that's what we're going to go over. Then at the end of each chapter, you're going to find abnormal findings, and then you're going to find always an example of how to document or write up that section. In this case, it's on page 224 and 225. So there's examples of how to write up the subjective and objective for the skin, hair, and nails. Now, you do not have skin, hair, and nails on your checkoff because you are doing that throughout the whole assessment. There is not one single section. You do it for every system. Then you end every system with abnormal findings. In this case, there's lots of skin disorders for you to look at. Starting on page 233, shows you some examples of pressure decubitus, stage 1 through stage 4. If you look over here on page 234, it goes into how to check for trauma and abuse in children. And then in the adult, and then it goes over cat, dog, human bites on page 235. When we switch over to 236, we can see some hemangiomas. We can see some port wine stains, some strawberries. We can see some spiders. They look like little spiders, angiomas. We can have what's called a venous lake. You'll see that a lot on older people. On page 238, it goes over petechiae and what that looks like versus ecdymosis and purpura. On page 239, we get some common skin lesions in children, anywhere from diaper dermatitis to candidas to impetigo, and boy, is that a good picture of impetigo, versus eczema. On page 240, there's some examples of measles in light versus dark skin, rubella, varicella, chickenpox. On page 241 shows you a good picture of dermatitis versus an allergic drug reaction. Good picture of a ringworm on 241 and ringworm of the feet causes peeling. Page 242 shows you some good cold sores versus shingles and Lyme's disease. And that's a good picture of Lyme's disease with that typical bullseye rash. Page 243 goes over how psoriasis and what you would expect to see it look like. Basal cell versus squamous cell carcinoma on the bottom of page 243. 244 shows you some good pictures of melanoma, Kaposi sarcoma, good pictures of a scalp ringworm on 243, alopecia. Then on page 246 shows you razor bumps, what we call razor bumps, cradle cap, head lice, someone who pulls out their hair, let's see, excessive growth of hair. We've got abscesses, scabies, good picture of scabies on 247. Then it goes into nail disorders on pages 247 and 248. Anything from clubbing to pitting to splintering, and that's how each chapter will be set up. It always ends with abnormal. Now we are covering normal. If you want to know a lot more about the abnormal, then you'll need to take my health assessment class online. And that goes into more of the abnormal. So we're mainly concentrating on the normal. All right, so if we're doing the skin, hair, and nails, again, pages 199 through 206, you can review. You're going to have to learn to consciously attend to skin characteristics. And the first thing you always want to know, is this your normal skin color? You always need a baseline because you may think the skin, wow, they look really, really pale, but they've always been that skin color. The skin assessment is, again, going to be performed throughout the assessment. It's not a section. It's in each system. You will use 2 skill sets, inspection and palpation. When we're looking at the skin, particularly on page 207, you will first always start out by looking at the color. When you look at the color, is it even? Is it consistent in color? Is there pallor? Are they pale? Is it yellow, jaundice? Are they cyanotic? So mainly you're looking at the color. Is it even? Is it consistent? Temperature. Are they hypo or hyperthermia? Are they warm to touch or are they cool to touch? Moisture. Are they dry? Are they wet? Texture. Is it smooth and firm? If this is an elderly person, it's probably not smooth and firm. Thickness. Is there any calluses on the palms or soles? Edema. It goes into grading of edema if they have any present on page 10. A +1 would be mild pitting with slight indentation, but there's usually no perceivable swelling of the leg. A 2+ is moderate pitting with indentation that subsides rapidly. 3+ is deep pitting with indentation that remains for a short time and the leg actually looks swollen. 4+ is very deep pitting that lasts for a long time and the leg is very swollen. Now you can say this scale is subjective and you're absolutely right because each examiner may, is it really a 2+ or a 3+? Depends upon the eyes of the beholder. For purposes though of testing and grading edema, that's what we do go by. Mobility and turgor. Talks about that on page 211. You pinch up a large fold of skin on the anterior chest under the clavicle area. Mobility is the ease of the skin to rise, and turgor is the ability to return in place promptly. So this is assessing for elasticity of the skin. So doesn't it make sense that someone who's dehydrated is going to have poor turgor? Someone who's very old is going to have poorer turgor than someone who is very young. Okay. Vascularity, checking for bruising and lesions. It talks about that on page 210, as well as checking for any tattoos. There's also something called cherry angiomas, which are normal. A lot of your older people will have these. These are just smooth, slightly raised, bright red spots. And again, over 30, you will start getting more and more of those. They are non-significant and do not cause any problems. Okay, there's sample charting on page, I'm sorry, let me look at the nails first. The shape and contour of your nails are very important to look at. This starts on page 213. You always want to look at consistency, color, and cap refill. So when you're looking at nails, think of the 3 C's: consistency, color, and cap refill. So are they smooth? Are they regular? Are they brittle? Are they splitting? What's the consistency of the nail? What's the color? Should be even and pink. Should be even in pink. For dark color skin, it talks about that on page 214. They may actually have what we call a linear pigment, and that's normal. For brown to black pigmented areas, and you may see on dark skinned people that, and it's just linear bands or strike along the nail bridges. Again, all people normally may have white hairline linear markings from trauma. It could be from picking at your cuticles, but it's not abnormal to see that from time to time. Okay. Cap refill. In children, when you press down on the nail, the color should return in less than 2 seconds. In adults, when you press down on the nail, the color should return in less than 3 seconds. So if it doesn't, then they would have poor cap refill. Okay. So when I'm looking at the nails, I'm looking for 3 things: consistency, color, and cap refill. Promoting health and self-care, you want to teach them about self-examinations. They need to check complete skin once a month. Now, if you look on page 215 in your book, it shows you how to do a complete skin assessment. This is the ABCDE rule. Adequate lighting, if you do find something abnormal, you want to go by the ABCD rule. On page 208 in your book, tells you what the ABCDE rule is. First, you're looking for asymmetry. If it's not regular, round, or oval, if it's got 2 halves, if it doesn't look the same, if it's asymmetrical, these are danger signs. B, look for the border irregularity. If it's got jagged edges, poorly defined margins, color variations. For the C, diameter, if it's greater than 6 millimeters, which is about the size of a pencil eraser, not good. Elevation or evolution. So if it's got elevation, So if it's got these signs, if you see a mole and then you go down your ABCDE rule and you see that it's asymmetrical with an irregular border, with color variations, with a diameter greater than 6 and it's elevated, they need to seek further follow-up. All right, so it says if you're going to do a complete skin assessment on page 215, you should do this once a month. You need to undress completely, it says. Check your forearms, your palms, spaces between your fingers, turn over your hands, study the back of your hands, face a mirror, bend over at the elbow, study your arms, look at your torso, your neck, down your lower legs, pivot, check out your side, check out your back, have a handheld mirror, check out your complete backside. Use the handheld mirror to actually look at your scalp, and then, of course, one to look at the soles of your feet. Now, I don't know about you, but I don't know anybody that does a complete skin assessment like that unless they have had some type of history of, and I'm sorry, I've just not been going through this, have I? Some type of history. Well, I've not done good at all. Woo, I finally got caught back up. I'll try to do better with that. Some kind of history of skin disease. If they've had some kind of skin cancer or something, then of course they are going to do a more detailed assessment. All right, so as far as charting, on page 224 is a sample chart of how to chart the skin in 787. You are not going to have to do that because you're going to do it throughout the assessment. Now, some nursing diagnoses that are common for the skin are impaired skin integrity, self-care deficit, and fluid volume deficit. Impaired skin integrity, self-care deficit, and fluid volume deficit. All right, so just like there's our nails, there's our teaching, and there's the sample charting for the skin, hair, and nails. All right, so just like the Energizer Bunny, we keep going and going and going. Chapter 13. All right, now this is where we get back to our handout. So I will be paying much more attention here to make sure I go by and flip the correct slides. You want to, again, review pages 251 through 258 because why? That's going to be where your A and P is located. That's going to be where your subjective data stuff. So if I was to flip over to 258 and 259, actually 259, 259 is where my objective data starts. I'm going to be using two skills at this time, inspection and palpation. So looking at the head and neck, if I was to go to my checkoff sheet, it says I have A, B, C, D, E, F, G, and H. I have went over A, B, C, D, E, F, G, and H. So I have given you an example of what you need to write. So if you go through here and you're writing this as we go, it helps you to keep up with that. So on the head and face, size and proportion in relation to the body. You can say it's normal cephalic with correct alignment. Hopefully their head is positioned midline. If it's not, then you would have to say that. Inspect the hair for distribution and abnormalities. You're looking at the color, texture, and distribution. Now that would be true color. Is it shiny? Is it fine? Is it straight? And is it normally distributed? Okay, so they have blonde hair, naturally blonde hair. It is fine texture, and it is evenly distributed. That would be an example. Okay. Inspect the scalp for discolorations, for scaling, nits, lesions, or inhabitants. So you're going to have to say that. As I'm inspecting the scalp, I see no discolorations, scaling, nits, or inhabitants. Again, if you don't say that and you're just looking at the scalp, I have no idea what you're looking for. So you're going to have to actually inspect, pull it apart. I'm looking for discolorations, scaling, lesions, nits, inhabitants. I see none. Now I'm getting ready to palpate. I'm going to be palpating your scalp. So as I palpate your scalp, I want you to tell me if you feel any tenderness. And then you palpate. I'm palpating the scalp now. I feel no nodules, masses, thickening, or tenderness. Okay. Then you would palpate the frontal and maxillary sinuses. Now you can do this later on. You can move this. This is just where I do it. On page 363, if you'll hold your hand where we're at and flip over there. You can see there it shows you how to palpate the sinuses, and they've got this in the nose, mouth, and throat section. So if you want to do it over there, that's fine with me. But the way that you palpate the sinus area is use your thumbs, press the frontal sinuses by pressing firmly up and under the eyebrows. So try that on yourself. You may feel a little bit of pressure, but you should not feel pain. If you feel pain, then they probably have a sinus infection. Then you would do the maxillary sinuses below the cheekbones, and you would apply pressure again. Of course, be careful not to put any kind of pressure on the eyeballs themselves. They should feel pressure, but no pain. Okay. Another thing you can do if they have that is have them bend over and then lean up. And if they have come up from that bending position, a lot of times they will complain of focal pain. All right, then going back to our chapter on page 259. Again, now we're going to look for facial symmetry. And of course, the face should be symmetric. Facial features should be symmetrical. Then you're going to assess for sensation of the face and scalp. Here's your first cranial nerve. Again, you can do all the cranial nerves together, or you can do them separately. So if you're going to choose to do them together, then what you're going to need to do is get you a piece of paper, write all of these cranial nerves down so that you don't miss any, because some of them you test for doing two different things. So the first thing you're going to do is assess sensation of the face and scalp cranial nerve number 5. That's trigeminal. So you would say, can you close your eyes and tell me when you feel this? So you would take a cotton ball, have them close their eyes, and you would put it on their face. And tell me when you feel this. And they're going to say now, now, and on their scalp now. And if they can feel it, then you would say cranial nerve number 5, trigeminal, intact. You do have to name the cranial nerves. Then you would say, can you close your eyes? Can you frown? Can you smile? Can you squint? And you would say that's cranial nerve number 7, facial. It's intact. Okay. So now we've already gotten 2 cranial nerves out of the way. The next section that we're going to go to is the neck. Okay. The next section we're going to go to is the neck. This is pages 259 through 264. Okay. Again, mainly in the neck, you're inspecting for symmetry of the muscles. You're going to inspect the neck muscles. Are they symmetrical upon palpation? So you're going to look at them and you're going to palpate them. You're going to palpate for tenderness. Then you're going to assess for symmetry of movement and strength of the trapeze muscle. And that tests cranial number 11, spinal accessory. So you move behind them, you put your hands on their shoulders and tell them to lift up against resistance. That would test cranial number 11, spinal accessory. Then number D, you're going to inspect and palpate the thyroid gland. This takes practice, practice, practice. If you look on page 263 and 264, it shows you how to do that. You're going to have some water, and you're going to have them drink some water. You can look on page 263 at the bottom and then see an example of an enlarged thyroid. Hers is very visible. The thyroid may move up when they swallow, but it should be non-palpable. You should not be able to palpate a thyroid. You can do the thyroid from the anterior or the posterior position. The most common way that new people do it is from the posterior position, and that's on page 263. On 263, it says to palpate, you move behind the person. You ask the person to sit up very straight, then to bend the head slightly forward and to the right. What that does is relax those neck muscles on the right side. Using the fingers of your left hand, push the trachea slightly to the right. Curve your right fingers between the trachea and the sternomastoid muscle. That's going to retract it slightly. Then ask them to take a sip of water. Again, the thyroid may move up under your palpating fingers with the trachea and larynx as they swallow, but you will not be able to palpate a huge mass, okay? So usually you should not be able to palpate a normal adult thyroid. If the person has a very long, thin neck, then you may feel the isthmus over the rings, okay? All right, so again, that takes practice, practice, practice. And I can put up some videos that would help you, and you can also just Google assessing the thyroid, and a lot of these YouTubes will help you along the way if you're having trouble with actually needing to see some of this stuff. All right, the next thing you're going to do is palpate the carotid arteries for amplitude, one at a time, and auscultate for bruits. This is on page 475. So you can do this in the neck area when you're doing the heart, when you're doing the pulses, or you can do them now. It doesn't matter as long as you do all of it. You always palpate the carotid arteries one at a time. You don't want to clog them both off. You'll cause them to faint. And you auscultate for bruits. When you get ready to auscultate for the bruits, you always have them hold their breath. Otherwise, you're going to hear breath sounds as you're listening. The pulse should be a normal 2+ with no bruits noted. So if you look on how to palpate the carotid artery on page 475, it's located central to the heart. You palpate each carotid artery medial to the sternocleidomastoid muscle in the neck. Avoid excessive pressure on the carotid sinus area to the neck, because if you cause excessive vasal stimulation, if you keep on pressing too hard, and they can faint. All right, and you don't want to compromise arterial blood flow, especially in the older patient. When you're getting ready to auscultate the carotid artery, it's on page 476. You're going to auscultate for the presence of what's called a bruit. This is a blowing, swishing sound that indicates blood flow turbulence. So you should not hear bruits. It tells you here to keep the neck in a neutral position and then lightly apply the bell. So you're going to listen with the bell, and you're going to listen in 4 areas: at the angle of the jaw, the mid-cervical area, the base of the neck, and then in the middle. Again, you want to lightly listen, and you do not want to hear bruits. The last thing you're going to do is check complete range of motion of the neck, and they should have full range of motion with no limitations. Now, when you think about range of motion and what you can do with the neck, you can bend it forward, you can bend it back, side to side, and then you can bend it all the way around. That's called extension, flexion, lateral extension, and circumflexion. And yes, it is better. You can say to the patient, can you touch your chin to your chest? Can you lean backwards? Can you touch your head to your ear to your shoulder on each side? Can you turn your head all the way around, twirl it around? Then you would say range of motion intact with extension, flexion, lateral extension, and circumflexion. Okay. The last part of the neck is the lymph chains. Okay. Now, these take some practice to get to know really well. But if you look on page 260 in your book, there's a good picture, as well as on page 254. So you can either go by 254 or 260, either one. So I've got my book to page 260. And I want you to go over these with me. And you need to use both hands to compare both sides symmetrically, except when you're doing the submental. When you're doing the submental, you can do just one hand. Otherwise, you should have both hands on each side comparing. If you do feel a lymph node, which normally you should not feel any lymph node, you want it to be movable, soft, and non-tender. So if you do feel a lymph node, you want it to be movable, soft, and non-tender, but you should not feel them. So I've got the lymph nodes here, and I'm checking the lymph nodes. So in front of the ear, that's number 1, preauricular. So feel both sides in front of your ear and go with me. Preauricular. Number 2 is right behind the ear, posterior auricular. Posterior auricular. If you slide down, occipital. Occipital is number 3. Go up to the beginning of your chin, and I don't care what order you do these. We're just going by the book as long as you can do them all. Submental is number 4, right up under your chin. Going along the mandible, submandibular is number 5. 6 is right below the earlobe. That is called the jugulodigastric, or also called tonsillar, and I don't care which one you call it. Number 7 is the superficial cervical, down just a little bit. If you keep going down all the way down that muscle, then you will go down the deep cervical chain. Go back, once you get down to the deep cervical chain, back into the V. Back into your V is your posterior cervical. And then have them bring their shoulders forward and their elbows and lean inward. That will clench up, and once they do that, then you can feel along the supraclavicular over the clavicular bone. So, again, the only way to get to know these and to be able to do them well is to do them over and over and over again. Preauricular, posterior, occipital, and you can do them in any order you want. Submental, submandibular, occipital, jugulodigastric, superficial cervical, deep cervical chain, posterior cervical, and supraclavicular. Again, if you do feel any, they should be movable, soft, and non-tender, but you should not be able to feel any. Sample chartings on page 268 and page 787 has example write-ups. Again, though, only put in your charting in this write-up what you actually do. Practice, practice, practice makes perfect. All right. So we're still a rolling. Chapter 14. Chapter 14 goes over the eyes. Pages 281 through 289 is a review again of the structure and function. Again, we're going to use 2 skill sets, inspection and palpation. We want our patient sitting up and at eye level. The external eye is what we are going to go over first, and the external eye is covered on number 5 and the internal eye number 6 on your checkoff sheet. EOM stands for extraocular muscle movement, so that's what we're going to be checking. So if you look on number 5, it says external eye, A, B, C, D, E, and E, A, B, C, D, and E, and I have A, B, C, D, and E. So again, I'm following your checkoff sheet. First thing you're going to have to do when you're doing the external eye is assess the cardinal fields of gaze. That will assess cranial number 3, 4, and 6. Oculomotor, Trochlear, and Abducens. The EOM strength is checked on page 292. So let's go to page 292. And starting down at the bottom, you're going to check the diagnostic position changes or the cardinal fields of gaze. Shows you how to do that at the top of page 293. It tells you that you're going to be leading their eyes through the 6 cardinal fields of gaze by asking them again to hold their head steady and follow the movement of your finger only with their eyes. So you hold the target about 12 inches away. So hold your finger about 12 inches away and ask the person to focus on it. Then you start moving it in each of the 6 positions as shown on the top of page 293. Hold it momentarily and move it back to the center. Progress clockwise. A normal response is parallel tracking of the eyes with both eyes. So one of the eyes shouldn't drift off. They both should follow that. All right? And you're also looking for lid lag during this time. Then you're going to assess the eyelids. Is there any drooping, discoloration, or masses? And of course, you've got to say that. I'm assessing the eyelids. I see no drooping, discolorations, or masses. Then you're going to inspect the eyelashes. The eyelashes are evenly distributed and placed. Now I'm going to palpate and inspect the lacrimal ducts for swelling and drainage. So you would have to do that, and it shows you how to do that on page 295. Page 295. You can see here, you ask the person to look down, and then with your thumbs, you slide the outer part of the upper lid up along the bony orbitants to expose the upper lid and inspect for any redness or swelling. Normally, the puncta drains the tears into the lacrimal sac, so pressure on that would cause drainage if they had it. So you will do pressure to the lacrimal apparatus as on the bottom of page 295. There's no swelling, drainage, or tenderness noted. Then you're going to inspect the sclera, conjunctiva, pupil, and iris. You are going to say if the sclera is colored, or if it's just white, or if it's bloodshot, whatever it is. Normal is for it to be white. Okay. The conjunctiva should be clear with no swelling or lesions. The iris should be flat and round and even colored. Then the pupil should be equal, round, and then ever how many millimeters. Normal millimeter size is 3 to 5 millimeters. Now you do need to keep in the back of your mind that about 5% of all people have pupils with 2 different sizes. So with that said, make sure that your patient's not one of those 5%, and you freak out if they got different size pupils, but come to find out that was normal and what they were born with. Now, as we're getting ready to start the internal eye, which is number 6 on your checkoff sheet, you'll see A through H. So you're going to assess vision with the Snellen Eye Chart, which is cranial number 2, optic. And remember, you've already told me you did that at the beginning of the assessment. This is on page 2. Let's see where it talks about that. 289. Okay, 289. On page 289, when you're getting ready to do the Snellen Eye Chart, if someone wears glasses or contacts, do you tell them to leave them on or take them off? I'd want them to leave them on, because if they don't leave them on, they're going to fail for sure. So you would just write with corrective lens, and missed one, 20/30 corrective lens. So you have to write whatever it was. With the Snellen Eye Chart, you want them at eye level, positioned 20 feet from the chart. They cover one eye not being examined. That's why you need the card. The normal sight vision is 20/20, with the optic nerve being intact. So you need to read over pages 289 and 290. Then you're going to assess pupillary size and reaction. When you're assessing pupillary size and reaction, this is cranial number 3, oculomotor. The pupils react equally to light. They go from a 4 to a 2 millimeters. That checks cranial number 3, oculomotor, and it's intact. Now, if you look on page 296, it tells you how you would chart that. On page 296, you can see there in the right eye and the left eye, they have a 3/1, so that means it was a 3, and it dilated to a 1. And that's how you would chart that in your notes as well. As far as assessing for direct and consensual light reflexes, direct light reflex is intact and relaxed to light, with consensual also being intact. So direct, if you talk about that, that's when you come in from the actual side. I'm sorry, I'm trying to find it here. And it talks about direct and consensual and accommodation. Now make sure when you're doing direct and consensual, you'll bring the flashlight from the side. And when you bring it from the side, you're only looking at the eye, one eye. Does it dilate? Does it react? When you're checking for consensual, you'll bring the light in from the side again. When you bring it in, then you look at both eyes, because the other pupil should also dilate as well, and that's consensual. So you're checking for direct light reflex by looking at one eye, and then consensual, does the other pupil react as well? All right, then you're going to assess for accommodation, which is Perla. When you assess for accommodation, and it talks about that on page 296, you're going to have them focus on a distant object. When they do that, say, look at the far wall. Their pupils should dilate because they're shifting focus. Then you will have them look at your finger from about 3 inches away from their nose, and the pupils should constrict. As you bring your finger towards their nose, it should converge as well, and it shows you an example of what that means on page 296. And that's how you check for accommodation. So you shouldn't write Perla unless the A at the end stands for accommodation, unless you're actually checking for it. So pupils equal, round, reactive to light, and accommodation is what that means. The last thing you're going to do with the eyes is check for the red reflex. You're going to dim the lights. You're going to set the ophthalmoscope at 0 diopters. You're going to approach the patient at a 15-degree angle. and you're going to obtain what we call the red eye reflex. So from about 10 inches away at a 15-degree angle, you're going to come in with the patient, and this is talked about on page 298. And when you see the light of the pupil in their eye turning kind of a reddish color or orangey red, then that's the red eye reflex. You see that a lot when people are taking pictures in cameras, and all that is, there was a reflection off the inner retina, and that just means the reflection is intact. So that if you don't see that, then there's other problems usually, a lot of times like cataracts or early cataracts that may be keeping that from turning red glow, the red glow. Okay. So sample charting is on page 310. Also in the back is on page 387. Repetition is the mother of all learning. You need to work at this. Now, if you copy and paste this link in and watch it, then it will show you how to use an ophthalmoscope appropriately. Okay. The ears are chapter 15. You need another sigh, take one. That's more of a groan, isn't it? Alrighty. Let's go to the ears, chapter 15. Pages 325 through 331 is just to read over. We are mainly just going to be inspecting and palpating when we think of the ears, okay? Now, I know this is what you feel like at this point, plugging your ears, okay? Because you're probably thinking, I can't do this. All I can say is, yes, you can. You're going to take this assessment one step at a time. But you can't wait till the last minute to start practicing. You got to do. The external ear, if you're looking at the external ear, you're looking at the position and alignment. Is it equal in size, appropriate in position and alignment? Then you're going to assess the auricles for discoloration and masses. And you're going to say that. I see no discolorations. I see no masses. Okay? So position and alignment, assess the auricles, and then palpate the auricles in the tragus. And it shows you where, if you're thinking about the auricles in the tragus, that's all the outer ear, all the way down. The tragus is the inner fold that can be pushed in to cover the ear canal. You're palpating that for tenderness, nodules, and masses. So you would say, no tenderness, masses, or nodules noted on palpation to the auricle or tragus. Then you're going to palpate what's called the mastoid process. And there's a picture of this where it's located on page 326. If you don't remember, it's the bone right behind the ear. So you would palpate that for any kind of tenderness. The ear canal and the tympanic membrane. You're going to assess for auditory acuity, which is cranial nerve number 8, the whisper test. So you would distract one ear, cover your mouth, whisper a 2-word syllable, baseball. And if they can hear that, then cranial nerve number 8, acoustic, is intact. Then you're going to inspect the external canals for swelling and drainage. No drainage was noted upon inspection to the external canals. I am now selecting the appropriate size otoscope cover. It's the largest one the ear can accommodate. Then I'm going to hold and use the ophthalmoscope. If you look on page 333, it shows you how to do that correctly. You hold it upside down while pulling the peanut up and taunt, up and back in the adult if they're 3 and over. Under 3, it's back, it's down and back. Then you're going to visualize the tympanic membrane should be a pearly gray color. If you look on page 326, it gives you an excellent visual for you visual learners of what you should see once you look inside the ear, and it will be very similar to this. So looking up in the ear, you're going to visualize the tympanic membrane. You're going to visualize and describe the cone of light. It's going to be at 5 o'clock in the right and 7 o'clock in the left if you were to visualize a clock. So if you look on page 326, just looking at this picture, am I in the right or the left ear? And if you said you were in the right ear, you're correct, because on a clock, that's about 5 o'clock. Now, you would also look for the bony landmarks. In this case, we're looking for the umbo. And you can see, if I find the cone of light, which you're going to find the cone of light as well, once you find the cone of light and go straight up where it's narrowing, it will always point you to the umbo. Then you're going to find the manubrium, which is the long part of the bone. And then the short process of the malleus is the upper part that sticks out. So those are what we're looking for. The tympanic membrane, the cone of light, the umbo, manubrium, and short process of the malleus, and that they're all intact. And if you look on page 340, it gives you sample charting as well as page 787. Now, I've also done a YouTube video here that you need to copy and paste so that you can actually see the inside of an ear. All right. For me, this will be the last chapter, I promise. So now you feel like clapping your hands. All right, so thinking about the nose, throat, and nose, mouth, and throat. This is in chapter 16 in your book. This is pages 353 through 361 that you need to read over. And again, we're mainly just going to use inspection and palpation, and I'm almost to my finish line. So when you're thinking about the nose, if you see your checkoff sheet and go by it, it's number 4. First, we're going to look at the external nose. Is it symmetrical, midline, proportionate? Is there any lesions or deformities? And if there's not, you're going to say that. The external nose is symmetrical, midline, proportional, with no lesions or deformities noted. Then you're going to look at the internal nose. You're going to assess for patency of each nostril. So as you're assessing for the patency of each nostril, you can do that when you're also doing the smelling, okay? So the smelling is what you will do patency when you check for the sense of smell. So you're going to look at the color of the turbinates, okay? And this is on page 362. So as I'm looking in the nose, it shows you what an example what the inferior and the middle turbinates are going to look like. Now you don't want to stick a light all the way up someone's nose. You only need to have them tilt back and push their nose up slightly and look in their nose with the pen light. Their nose, it looks like almost little shelves in their nose on the outer part for looking at the turbinates. You're going to see the middle and the inferior. You will not be able to see the superior. They should be light red in color. You can see here, you're also looking for a deviated septum. The septum shows you a picture of a deviated septum on 362. You're going to see the nares are going to be different size, and usually the deviated part will have some type of closure or blockage. Okay. Alrighty then. Of course, you may see polyps. Those are smooth, pale gray, mobile, non-tender areas located in the nose. All right. You're also going to assess for drainage and exudate, and you would say no drainage or exudate noted or present if you don't see any. Septal deviation, we've already went over, and again, it was on page 362. Assess for lesions. No lesions were noted when I looked up the nose. Then I'm going to assess the sense of smell, cranial number 1, which is olfactory. So I'm going to have them close their eyes. I'm going to occlude one nostril, and then I'm going to hold a scent under one nostril and ask them to identify it. Then I'm going to do the same on the other nostril using a different scent. If they can smell both of them, then their olfactory cranial number 1 is intact. All right, then we're going to go to the oral pharynx. This is where you have to put on gloves. Now, if you want to put on gloves on any other part, you're more than welcome to, but this one is a have to. So the first thing you're going to do is assess the lips and the gums starting on page 364 in your book. You're going to assess, and this is number 3 on your checkoff sheet. Assess the lips and gums for color, condition, lesions, and inflammation. The lips should be red. Moisture should be present with no cracking or lesions noted. The gums will be pink with no inflammation or lesions noted. Then you're going to assess the teeth for caries and malocclusions. No caries or malocclusions noted. Malocclusions, when they have a bite, does it have the overbite? Teeth are white, straight, and clean, and fillings are present. Then you're going to inspect the buccal mucosa and the tongue for color and condition and lesions. The mucosa should be pink, smooth, and moist. The tongue should be pink and even without lesions. Well, how do you know it's got does or does not have lesion? On page 365, this is what you need your gauze pad for. You are going to take with your gloved hand and hold the tongue with a cotton gauze pad, which does not feel good. You need to do that to yourself so you know what it feels like. Take a pen light and inspect for any white patches or lesions along each side of the tongue, and then palpate under the tongue as shown on page 366. Bet none of you have hardly ever had that done to you. Then you're going to have them stick out their tongue to inspect for nodules. Stick out their tongue also to inspect for movement, abnormal movement, and fasciculations. This is cranial nerve number 12, hypoglossal. And if they stick their tongue out and there's no abnormal movements, then you can say cranial nerve number 12, hypoglossal, was intact. Then you're going to move to inspecting the color and condition of the tonsils, uvula, and pharynx. Tonsils are pink, no exudate, and they're a grade 2. Page 367 in your book talks about grading. You can see here a +1, +2, +3, and +4. +4 is when the tonsils are actually touching and kissing. 3, they're almost to the uvula. 2+, they're midway, and 1+, they're buried almost within that. A normal is a 2+. You're going to grade the tonsils. You're going to assess the parotid ducts or the Stenson's duct for inflammation and obstruction, which is cranial nerve number 9. Now, the Stenson's duct should be intact with no inflammation or swelling noted, and that would be cranial nerve, again, the glossopharyngeal, cranial nerve number 9. You would check the Stenson's duct by looking in the mouth and making sure it's located across from the second molar in the mouth, and make sure that you directly into the buccal mucosa. Once you look into the mouth, you should not see any swelling in that area, and that checks for the Stenson's duct. Okay. Then you are going to assess the integrity of the hard and the soft palates on page 367 and 366. You'll see there at the top on 367, it shows you that you're also checking for the integrity. The hard palate should be white with irregular transfer rugae present, and the soft palate should be pink and smooth. You also want to assess chewing, which is cranial nerve number 5, trigeminal again. So this is the second time we've done trigeminal. So you're going to put your hands on both sides of their jaw and have them clenched down. And you're also checking for TMJ. You want to assess for adequacy of saliva, which is cranial nerve number 7, facial. Remember you did that one earlier when you had them frown and smile and puff out their cheeks. You're also going to assess cranial nerve number 9 again with the gag reflex, but you can verbalize only. You do not have to do this one with the glossopharyngeal. Assess swallowing. Cranial nerves number 9 and 10. If they can swallow, glossopharyngeal and vagus will be intact. There's sample charting on page 372 and sample charting again on 787. So, your assignment, you are required to complete a comprehensive physical exam on your partner. You need to practice this head-to-toe assessment before you do it. And then turn in a typewritten assignment the day that you do your head-to-toe assessment. All right, if you have any questions on this, let me know. It's really not that bad. You can do it.